This video is over red blood cells and blood clotting. So the components of blood. So what is blood made up of? So obviously the plasma, which is the liquid portion of blood, and then the formed elements, which are the blood cells. Red blood cells, white blood cells, and platelets. Plasma volume is generally 55%, but that depends on hydration of the patient, body mass of the patient, and body composition. Generally, people with more skeletal muscle hold more body water. So as opposed to fat mass holds less water, skeletal muscle mass holds more water. So it does vary, and then obviously hydration, and that's really important for when we talk about hemoconcentration. So textbook answers: plasma is 55% of blood and 45% is formed elements, the vast majority of which is red blood cells. Okay, that little buffy coat. So what the buffy coat is, the buffy coat is a thin line here between the plasma and the red blood cells in this test tube, and that's what contains the platelets and the white blood cells. So how do we do this? Well, you take a test tube of blood, you put in a centrifuge, a machine that spins around really, really fast, and it'll separate the components of blood based on density. So the blood cells, especially the red blood cells, will fall to the bottom because they're the most dense, where the plasma is the least dense, so it rises to the top. And you might see this done with platelet-rich plasma injections when they're injecting people with, they pull up the platelets because they have growth factors to help with healing musculoskeletal injuries. So it's done pretty often for that. So again, plasma, it's the water or liquid portion of blood. It's about 90% water, give or take, depending on hydration status. 7% proteins. So proteins are extremely important in blood. We call them the plasma proteins. The primary plasma protein is albumin. So albumin is the most abundant. So this is made in the liver, and it maintains the plasma oncotic pressure, which is an inward pressure into the blood vessels. And we haven't talked about fluid dynamics yet, but we will get there. So albumin is very important for that. So if albumin's low, we have a decreased inward force of fluids into our capillaries. It can cause edema or fluid basically to leak out of our blood. We see that in liver disease like cirrhosis when they're not making albumin. We see that in nephrotic syndrome when people are losing lots of protein through the urine. And we also see that in potentially malnutrition because there's low protein intake, so not enough protein to actually make these plasma proteins. So kwashiorkor is protein malnutrition. Then there's globulins. There's all kinds of globulins. Alpha and beta globulins do all sorts of different things. Some bind to hormones like sex hormone binding globulin, thyroid hormone binding globulin. There's others with other functions. And then gamma globulins, those are a fancy name for antibodies. So these are also proteins that are not made in the liver. These are actually made in the immune system, but gamma globulins are antibodies. Now the last one, this is very important, fibrinogen. So fibrinogen is what forms blood clots. So your clotting factors are proteins floating on your blood in inactive form. And fibrinogen is the clotting factor, or the factor, however you want to say it, the product, whatever the protein, that when it gets activated, fibrinogen into fibrin, it can form a blood clot. And that's what a blood clot is made out of, or a thrombus we'll talk about, is just fibrin. Okay, so that's about 97% of plasma. Then we have electrolytes. There's sodium, your calcium, potassium, magnesium, chloride, your bicarb, all that stuff. So nutrients like glucose, amino acids, triglycerides, free fatty acids. You got blood gases, right? CO2 and oxygen, all your hormones, testosterone, estrogen, cortisol, insulin, so on and so forth. And then we have waste products like creatinine and uric acid and urea and stuff like that. But that'll come later when we talk about the kidneys. Okay, the buffy coat is white blood cells and platelets. White blood cells, we'll talk about these when we get to the lymphatic system, when we talk about immunity. There's 5 types. There's neutrophils, lymphocytes, monocytes, eosinophils, and basophils. So this is an order of the most abundant to the least abundant. So neutrophils, lymphocytes, monocytes, eosinophils, basophils. This is part of your immune system. We'll talk about it later. So what's a normal count of white blood cells? 5,000 to 11,000 per microliter of blood. Okay. Platelets. Platelets are actually not full cells. They're fragments of cells. So if you have these big cells called megakaryocytes, they break down into small pieces of cells, and those are platelets. Okay, they're fragments of these big cells called megakaryocytes. So these form the platelet plug. They get activated when there's exposure of subendothelial collagen, and there's a factor called von Willebrand's factor, which activates the platelets. They get bigger and change shape and stick together, and they form this plug. And we'll talk about that. There's about 150,000 to 400,000 per microliter blood, so vastly more than white blood cells on a normal basis. And then red blood cells, making up greater than 99% of your formed elements. Well, we look at those numbers. Well, for our red blood cells, we'll talk about more details we'll focus on. So red blood cells, so these are covered in hemoglobin. Their main function is to carry oxygen to tissues. So how many of those do we have? Well, males tend to have higher numbers than females, and a lot of that's due to androgenic hormones like testosterone increase red blood cell mass. So some drugs like similar testosterone, like anabolic steroids that have been developed in the past, have actually, why did they develop them? They were developed for anemia because they'd raise red blood cell count. So a male average count, and again, this differs by lab, 4.7 to 6.2 million per microliter. So talking millions compared to hundreds of thousands of platelets to thousands of white blood cells. Females, 4.5 to 5.5 million per microliter. So a lot of red blood cells. So let's focus on red blood cells. So how are red blood cells made? Well, they're made in here, the red bone marrow, So there's two kinds of marrow, yellow marrow, which is just fatty marrow, and then red marrow. I drew a femur here. This is my poorly drawn femur. And there's red marrow up at the hip. Okay, so red bone marrow doesn't make red blood cells. It makes red blood cells, white blood cells, and platelets. They're all made in your bone marrow. So how is this controlled? Well, erythropoietin. So this is a hormone released from these special cells in your kidneys. And if those cells, they monitor oxygen content. If they note hypoxemia, so this word hypoxemia, so hypoxemia, low blood oxygen, that will stimulate them to release this hormone erythropoietin. Erythro, we know erythro is the root word for erythrocyte, or red blood cell. So this is going to travel to the red bone marrow and stimulate erythropoiesis, which is the fancy word for making red blood cells. And we got our red blood cells. So red blood cells, they live for about 100 or 90 to 120 days. So that's why hemoglobin A1C is just measuring glycosylated hemoglobin, meaning hemoglobin with glucose stuck onto it, and it's a percentage, right? So if your hemoglobin A1C number is 5.2%, well, 5.2% of the measured hemoglobin is glycosylated. Makes sense? So more glucose, more sticky stuff, right? So when red blood cells, let's talk about red blood cells. So they're biconcave discs. This is my awful drawing. So they're basically like flat on the side and here, and they're kind of like donut shaped. They lack a nucleus, so they extrude their nucleus before they're released. They form these biconcave disc shapes. Down here, this is a sickle shape. This is what happens in sickle cell anemia. Red blood cells, when they drop off their oxygen, they'll sickle sometimes and change shape. We'll touch on that. Okay, so they're covered in hemoglobin. Down here's a picture of hemoglobin. Oh, wow. It has 4 subunits, 2 alpha subunits, alpha, beta and beta. And these are made of globulin, so this very complexly folded protein. In the middle, it has heme. So it says iron here. The heme is in the middle of each subunit, and the heme contains iron. And they're linked together in the middle. So each of these subunits holds an oxygen. So 1, 2, 3, 4. And the red blood cell surface is covered in hemoglobin. So we need iron to make hemoglobin, hence why one of the most common causes of anemia is iron deficiency anemia. So we need to have adequate iron to make this hemoglobin. So what happens when red blood cells are done for after 190 to 120 days? In the spleen. So the spleen is part of the lymphatic system. The spleen has special capillaries called sinusoidal capillaries, the big holes in them, that take up these little red blood cells, because red blood cells usually don't leave the blood vessels. They shouldn't do that. And they break them down. When they break them down, all the pieces and parts end up, or some of them end up in the liver, because the portal circulation, which we'll talk about later, so the splenic vein drains into the hepatic portal vein, all that's going to the liver. So the liver stores iron, so our liver is very high in iron content. And then we also wind up with these two products, bilirubin and biliverdin, right? So from heme we get iron, and then it's bilirubin, biliverdin. These are actually bile pigments, and we release these through the bile. The gallbladder stores, concentrates, and secretes bile. Bile is made actually in the liver, and bile goes down into your intestines and helps emulsify fats. So these bile pigments give color to the bile and give color to your stools. So when someone is jaundiced, bilirubin's building up in their body. If they're not excreting it properly, well, then they have, we call acholic stools or clay-colored stools. So this is linking the bone marrow to the kidneys, to the spleen, to the liver. So the liver is going to take up the iron and then form this bilirubin, biliverdin. Those are the bile pigments that are excreted in bile. Okay. So you can see another cause of jaundice would be lots of breakdown of red blood cells. So if you had some kind of hemolytic anemia, you're taking up tons of red blood cells, that could potentially lead to jaundice if you're over the liver. Jaundice is high bilirubin right here. If there's too much red blood cell breakdown, the liver can't keep up. Okay. So different anemias. Again, we don't need to know all the specifics of here. I don't know how to move my head out of the way. So we could see low red blood cells, low hemoglobin, low hematocrit. We'll talk about our red blood cell indices next. So iron deficiency. So this could be due to increased need of iron, like during pregnancy, decreased iron in the diet, like in people with vegan diets, we can see that, or slow bleeding. So a bleeding ulcer, heavy menstruation called menorrhagia, or even if you donate blood very frequently, over time you can deplete your iron stores. So it's like we're losing actual blood, but what you do is you end up depleting iron stores over time. So if you donate blood all the time, you could have low iron. Usually it would reflect in anemia, obviously, and they check your hemoglobin at the Red Cross when you donate blood, but you can deplete your iron stores over time. So pernicious anemia and folate deficiency. So these cause the same type of anemia. Pernicious anemia is because you're lacking this thing called intrinsic factor, which you need to absorb vitamin B12, and it's made in your stomach. Some older people get this. Sometimes there's an autoimmune cause to those special cells in your stomach that make intrinsic factor. So that's why if you're deficient in B12, you need an injection, because you take pills, you might not absorb the B12. That's a waste. You inject it into the muscle, gets absorbed from the muscle right into the bloodstream, and does not have to be absorbed in the gut. Folate deficiency, so this is usually a deficiency in the diet. So both cause problems with developing DNA in the red blood cells as they're developing in the bone marrow. And here you wind up with these very large red blood cells, or it's a macrocytic anemia. Well, iron deficiency, we have small cells, but we'll talk about that. Anemia of chronic kidney disease. So, well, where's the hormone made that stimulates the production of red blood cells? It's from the kidneys. So if your kidneys are scarred up, getting into the later stages of chronic kidney disease, you're not making as much erythropoietin, your red blood cells can go down. Aplastic anemia, so this is bone marrow failure. So sickle cell and thalassemia are both genetic disorders. So sickle cell anemia, there's an abnormality of the red blood cell. So here they turn to a sickle shape. So we don't have blood smears to look at, but what happens is when the red blood cells drop off their oxygen, they can actually change shape into an actual sickle shape. And they usually don't go back. So these have to get taken up by the spleen and broken down, but these can include small vessels like capillaries and cause lots of pain and lots of different issues. So they need oxygen and they need to stay well hydrated. Talking about hemoconcentration. So thalassemia, so this is an abnormality of hemoglobin. So it's a hemoglobinopathy. So there's alpha and beta thalassemias where one of the subunits isn't formed right, so it can't carry oxygen properly. Okay, red blood cells. These are red blood cell indices. So we got a red blood cell. We get a CBC, a complete blood count. We see a red blood cell count. So here's the numbers for males and females. Again, varies by lab. So you have about 5 million per microliter of blood. Look at the hemoglobin. How many grams per deciliter? Males 14 to 17, females 12 to 15. Again, varies by labs. Hematocrit, the percentage of blood that is red blood cells. Okay, because red blood cell count is the number of red blood cells per microliter. Hemoglobin is the amount of hemoglobin you have. Hematocrit is the percentage of your blood that is red blood cells. So this can change based on hydration. So if someone's dehydrated, well, their hematocrit will go up. If they increase their hydration, meaning increase their plasma volume, well, hematocrit will go down. So we call this hemoconcentration. So if you go donate plasma and lose a bunch of plasma, you keep your red blood cells. So after you donate the plasma, your hematocrit will be higher. That's why they tell you to drink fluids. So general rule to see if someone has hemo concentration or not, this is a very general rule. Well, you take hemoglobin, you multiply it by 3, and that should give you roughly the hematocrit. So if someone has a hemoglobin of 15, their hematocrit should be about 45%. But let's say their hemoglobin's 15 and their hematocrit's 50%. Well, it should be 45. Why is their hematocrit higher than what there should be based on the hemoglobin? That could be due to dehydration, so reduced plasma volume. Now these things are over here. So you keep looking at your CBC and you see all this stuff, and this stuff you just skip over. So MCV, your mean corpuscular volume, is just the mean average corpuscular cell volume, the size. This is the average red blood cell size. So in iron deficiency, we see microcytic anemia, so the red blood cells are small, right? If they're normal, it's called normocytic anemia. And if they're large, like in B12 and folate deficiencies, it's called macrocytic. So average red blood cell size. Now mean corpuscular hemoglobin is the average red blood cell hemoglobin. So this depends how much hemoglobin's on the red blood cells. So again, in iron deficiency, because we're low in iron, we have less hemoglobin. We have what we call hypochromic. Some people say hypochromatic or hypochromic. The blood cells are pale because they have less iron. They're not that dark red. Normochromic means there's no change. Hyperchromic means it's extra dark because there's potentially extra hemoglobin with extra iron. There's also something called MCHC, which is mean corpuscular hemoglobin concentration, which is fairly the same, but it's a concentration. Red blood cell distribution width. So this is the variation in red blood cell size. So if you have a microcytic or a macrocytic anemia, you will have a expanded red blood cell distribution width. It'll be larger. It's because if you got iron deficiency anemia, you're still going to have normal cells, but then you're going to have some small cells. That widens it. So you have a macrocytic anemia, so you have some normal cells, but you got some big cells. Well, it goes the other way, but it's still expanding the width. So increased red blood cell distribution width. Okay, blood clotting. So there's 3 steps to blood clotting. So we've got vasospasm, when the blood vessel spasms and contracts. We've got platelet plug formation, and then we have the coagulation cascades, which is next. So the initial thing, so let's say there's a trauma, what's going to happen, the blood vessel is going to spasm. So it spasms, and when it spasms, the smooth muscle in the blood vessel wall will constrict, and it'll try to constrict it so less blood is leaving. So we see the layers of the blood vessel here. So tunica adventitia is the outer connective tissue layer. The tunica media is the middle layer. It's made of smooth muscle. And we have the tunica intima, which has 2 portions, the subendothelial collagen underneath the endothelium, or the basement membrane, and then the endothelium. This is the surface that comes in contact with the blood. This is really important. It provides substances like nitric oxide and prostacyclin, and what they do is they cause vasodilation and they prevent blood clotting. So endothelium staying intact is very important. Anything that damages the endothelium increases risk of forming abnormal blood clots. We don't want that. But if there's trauma to the vessel, you'll have vasospasm. And then when platelets, which are floating around in blood all the time, the little fragments of these megakaryocytes, if they get exposed to the subendothelial collagen, there's something in there called von Willebrand's factor. Von Willebrand's factor stimulates the platelets to activate. Platelets release serotonin. They have increased, they're not really cells or fragments of cells, but increased intracellular calcium. It tracks them together, they change shape, they enlarge, they stick together, and it's called platelet aggregation. So it's basically like if you have a pipe that's leaking, you stick plumber's putty on there, it's a temporary a temporary fix, right? And while this is happening, the coagulation cascades have already started. We assess platelet function with bleeding time. So you make a 1 centimeter long by 1 centimeter deep cut on the anterior forearm, and you put a blood pressure cuff on the upper arm and pump it up a little bit, and you wait to see how long it takes for someone to stop bleeding. That's called the IV method. There's a couple of different methods. This is not done very often clinically. This is just academic. So I don't think it's done very often. So drugs that block platelets, so platelet inhibitors. So aspirin, Plavix, Tyclid, these are antiplatelet drugs. Okay, this is showing turbulent blood flow in here, so this is beyond after the platelet. This isn't the platelet plug, it's beyond there. So again, endothelial damage is going to expose the subendothelial collagen. It can activate platelets and get platelet aggregation. Okay, the coagulation cascade. So these start up right away, but platelet plug is faster while these are going through their steps. So what are these Roman numerals? Always Roman numerals. It's because these Roman numerals, they're for each clotting factor. Clotting factors are proteins mostly made in the liver, right? And they need a lot of them need vitamin K. Some need vitamin K to form these. Okay. So vitamin K deficiency could cause increased bleeding times. You don't want to say blood thinning. You want to say increased bleeding times. So factor 12 starts off the intrinsic pathway. Factor 7 starts off the extrinsic pathway. So when these are exposed to subendothelial collagen, there's a couple different things for each one. One's tissue factor, one's exposure of negatively charged particles or substances like proteins and collagen will stimulate them. You don't need to know all those details. So 12 gets activated 12A. 12A activates 11 to 11A. So A stands for A stands for active. So 11A then converts or activates 9 into 9A. So 9A plus 8A will activate this thing called factor 10. Factor 10 is the common factor. The extrinsic pathway, you get factor 7. That's going to be activated to 7A, and that's going to convert 10 to 10A. So these two separate pathways are going on at the same time, but they're all coming together here at the common factor, factor 10. So and then I'll come back to that. So factor 10 is a common factor. So once it's activated at 10A, this helps convert prothrombin into thrombin. Then thrombin will stimulate fibrinogen to become fibrin. So anything O-gin is an inactive. So we call them zymogens. And once it's fibrin plus factor 13, that helps stabilize the clot. And you form this stable fibrin mesh, this protein, fibrinogen is a protein, this stable blood clot. And you heal your vessel, and then the vessel can heal up with growth factors as it goes through the inflammatory phase and proliferative phase, heals itself. But you don't want that blood clot to sit there forever, so you need to get rid of it. How do you get rid of it? Well, plasminogen, another zymogen, gets activated into plasmin. So what does that is this enzyme called tissue plasminogen activator, TPA, activates plasminogen to plasmin. Plasmin will dissolve the blood clot. The end. So what labs do you look at here? So to evaluate the intrinsic pathway, we look at activated partial thromboplastin time, or APTT. So heparin drugs will increase the APTT, like heparin, or low molecular weight heparin, like enoxaparin. We also call it Lovenox. What evaluates the extrinsic pathway? Well, this is a prothrombin time, or PT. And then INR, which just stands for the International Normalization Ratio. They just normalized PT, so it's a nice 1.0 is a normal number. So when people are on warfarin and they have a target number, it's a lot easier to figure that out. So warfarin will increase clotting time here, so it'll elevate the PT and elevate the INR. So warfarin's a vitamin K antagonist. So Xarelto will block factor 10. Direct thrombin inhibitors will block things like thrombin, so different pathways here. And then TPA, we can give someone exogenous TPA, which is a clot busting drug. So if someone has a pulmonary embolism or something that's life-threatening, you could give TPA, which will bust the clot up. So you have to be very careful with these due to the risk of bleeding, but they'll turn plasminogen into plasmin, and plasmin will dissolve the blood clot. So this is Virchow's triad. So what determines if blood should clot, like for abnormal blood clots? Well, what predisposes to that? So endothelial injury. So any injury to the endothelium, if you're exposing the subendothelial collagen in any way. So that could be from trauma, it could be from surgery, because surgery is still controlled trauma. And you're cutting blood vessels and cauterizing vessels and moving vessels around. So turbulent flow. So remember, we talked about blood being a nice laminar or layered flow, where the blood in the middle is moving the fastest, the blood towards the outside is moving the slowest because there's more drag against the endothelium. So the nice laminar flow is good. If we have turbulent flow or blood sloshing around, it's more likely to damage the endothelium. So we see that with high pressures like hypertension, or if there's any abnormalities in the vessel. Sometimes there's kinks or turns in the vessels that might predispose to damage. But a good example is an atherosclerotic plaque. If there's plaque buildup, well, that's going to cause an abnormality in the lumen of the blood, and blood's going to have to flow over that plaque, flow over it, and that's going to cause the blood to be turbulent. And it's more likely to damage the top of that, rip the top off of the plaque, and then now you've got a thrombus and you have a myocardial infarction or ischemic stroke or whatever. So blood stasis. So if blood is not moving, so we need blood to keep moving, especially the venous blood in the legs. We need to get it back to the heart and keep our circulation going. So immobilization. So if someone's post-op, they're not moving around. So, or they have a cast on. So especially for DVTs and lower extremity stuff, someone's in a short leg cast, they're not moving their foot, they're not using the musculovenous pump. So blood doesn't really pool in the feet. It's not really the right term. It's not like pool. It just takes longer to get back to the heart. Well, the longer it sits around, the more likely it is to clot. So someone could just be in a hospital bed. It's why they usually get some kind of VTE prophylaxis, venous thromboembolism prophylaxis, like SCDs, or medications like sub-Q heparin or Lovenox. So travel, so long plane rides or long car rides where you're not moving your legs and pumping that blood. So really allows our risk factors for VTE. Circulatory issues, so heart failure or venous insufficiency. So if you just don't have healthy veins in your legs and those veins are stretched out or scarred due to previous blood clots potentially, or it's genetic, lots of different causes, and blood is quote unquote pooling in the legs. We also see blood stasis like in the heart if someone has AFib and then the blood is kind of sticking around the heart longer and you can get a thrombus in the heart, then a piece of that breaks off and embolizes and goes into the brain and cause a stroke. Hypercoagulable states, so cancer is a big one. Smoking, any estrogen-based birth controls or hormone replacement therapies can increase your risk. And then there's genetic and acquired factors. So there's genetic diseases like protein CNS deficiency. There's things like factor V Leiden that increases your clotting or decreases your clotting time, so the likelihood of your blood to clot. There's acquired things like antiphospholipid antibody syndrome, where your blood just more likely to clot. So most people be very careful. So thrombus versus embolus. So thrombus, this is just a piece of fibrin that developed because blood started clotting in a vessel abnormally. Okay, could have happened in an artery, could happen in a vein. So coronary artery, cerebral artery, could happen in a lower extremity artery, could happen in a vein, so a deep vein in the leg. It could happen to the hepatic veins. It could happen in all kinds of veins, so veins or arteries. But if a piece of that breaks off and moves to the circulation, then that's called an embolus. So the venous example, hey, you got a patient, they're post-op, they're smoking, they're immobilized, they develop a DVT in the leg from being immobilized or from potential surgery and immobilization that forms in the deep veins of the calf and or thigh. A piece breaks off. As soon as it breaks free, it quote unquote embolizes. Now it's an embolus, travels to the pulmonary arteries, gets stuck in one or the other or both if it's a saddle embolus, and then you get a big problem. So this can happen in the arterial end, so you develop a thrombus in the heart when someone has AFib. Let's say you develop a thrombus there called a mural thrombus. A piece breaks off, enters the cerebral circulation, and causes a stroke. So that is it.